Hi, I'm David Playford. I'm a cardiologist. I'm the Professor of Cardiology at the University of Notre Dame. And apart from being a clinical cardiologist, I'm also an imaging specialist and researcher. And I also do have an artificial intelligence program. So I wanted to talk a little bit today about cardiovascular risk and then what we can do to try and pick cardiovascular risk and how we can find a better way of try to be prepared for it potentially. So when I'm thinking about cardiovascular risk, I'm thinking first of all about the traditional risk factors. And some of these risk factors include high blood pressure, high cholesterol, smoking, diabetes, and a family history of heart disease. So what do I mean by each of these? So high cholesterol has I suppose, a few different meanings. There's something called familial hypercholesterolemia, which means you're born with a very high cholesterol caused by a genetic abnormality. And that very high cholesterol persists throughout life. And the longer you're exposed to a very high cholesterol level, the more likely it is to cause cholesterol buildup in the walls of the arteries. And as that increases, the chance of heart attack also goes up. Familial hypercholesterolemia can be detected by a genetic test, but a lot of people who have familial hypercholesterolemia feel perfectly well and are unaware they've got a problem until somebody goes looking for it in them individually. Second thing that we would look at is whether the cholesterol may be relevant in context of other risk factors. So in cardiology, we're trying to look at things on their own, sort of out of context. We try to look at things in context of how things match together in association with other risk factors. So we do a thing that we call risk factor assessment, and so we do that using a series of probabilities, I suppose, where we linked one risk factor with another risk factor and see how they interact to increase somebody's chance of potentially having a heart attack in the future. And so we have various different scoring systems that we use, and the bottom line is that the trouble is that even if we do this carefully and we really assess somebody's risk in detail, we can never exactly predict what's going to happen in the future. We just give a best estimate, I suppose, based on the information we have available. Just briefly talking about other risk factors, high blood pressure. So high blood pressure is a well-known risk factor, not just for heart attacks, but also for strokes and other heart events. The high blood pressure is really defined by a blood pressure above 140 millimeters of mercury systolic. But in fact, an optimal blood pressure, perfect blood pressure, I suppose, is one that's around maybe 125 millimeters of mercury, so a lot lower than the cut point we would use to diagnose it in the first place. And so we often use treatments to try to get the blood pressure down to normal levels, particularly if the risk overall of a future event is high. Talking about other risk factors as well, so type 2 diabetes is a well-known risk factor for heart disease. Those who have high blood pressure and high cholesterol often also have risk factors for diabetes as well. So type 2 diabetes, once it's been identified, is really something we need to treat to try to minimize the chance of that causing significant cholesterol buildup in the arteries. And then talking about a family history of coronary heart disease, that family history isn't necessarily related just to cholesterol. There could be other genetic abnormalities that somebody's born with that can increase the risk of developing heart disease. Once we have all of this knowledge, we know the blood pressure, we know the cholesterol, we know the smoking history, we know the history of diabetes, and even the genetic family history. Even then, it's really hard to pick that necessarily who's going to go on to have a heart attack in the future. So we have newer forms of cardiac imaging that are really very good now in being able to pick coronary disease and whether there's cholesterol buildup in the arteries. And the test I'm talking about is coronary CTs, or cardiac CT. So a calcium score you may have heard of already is one of the very commonly used tests now to see whether there is long-term cholesterol buildup in the arteries. So calcium scoring gives us the ability to actually measure directly how much calcium there is in the walls of the arteries. A calcium score of 0 basically means that there's no calcium buildup, which is a sign that there hasn't really been much exposure of the arteries to cholesterol over time. And so older individuals, let's say somebody over the age of 65 or 70, if there's zero calcium, then that's pretty much excludes significant heart disease, and that's very reassuring. But in a younger person, let's say somebody between the age of 40 and 50, a calcium score of 0 doesn't really give that much reassurance because there hasn't been enough time yet to expose the arteries to high cholesterol, and so it's possible that there may be cholesterol buildup, but without any calcium there yet. So what we tend to use in younger individuals is CT, coronary angiography, which gives us a contrast injection that's given through a vein usually in one of the arms, that then fills the coronary arteries, and a CAT scan is taken while it's filling the coronary arteries, and we can really see in detail what the wall of the artery looks like and whether there's any cholesterol buildup there. It's a really good way of picking early cholesterol buildup in the arteries, or atherosclerosis. So that gives us a pretty good picture of overall whether there's coronary artery disease present. That's very helpful for making a decision on whether we should treat somebody, to prevent a future heart attack from occurring. Now I've talked about risk factors, I've talked about coronary CT, but even with this information, we still don't know really exactly what's going to happen in someone's future. We can give an estimate, we can give a prediction of risk, but we can't absolutely know what's going to happen. One statistic that's really important in making decisions of what to do is what happens if somebody has a heart attack. 50% of all first heart attacks are fatal. And this is a really scary statistic, but I'm sure that you may actually know somebody who's had a heart attack that they didn't survive from. And what we're trying to do is increase the chance of somebody's survival, even in the unfortunate circumstance where they have a heart attack. So the first thing we could do, if we possibly can, is to prevent the heart attack from occurring. We treat risk factors, we do whatever we can to minimize risk. But even if we do that, there are some people that we just couldn't pick it. We just didn't know they were going to have a heart attack. And so those are the people we also we want to try and identify. If those people, if that individual has a heart attack, we want to be prepared. So we want every tool that we have available to be able to potentially deal with that if it occurs. In the event of somebody having a heart attack, then as you I'm sure know, the right thing to do is to ring 000. So somebody presents with chest pain, they've got this classic central discomfort or just a sudden unexplained breathlessness, collapse, then 000, call an ambulance, get to hospital as fast as possible, and then we can administer the appropriate treatments. The other thing I want to mention is about what happens if somebody collapses. So somebody goes unconscious. Well, if somebody goes unconscious in the setting of a heart attack, usually that's a cardiac arrest that's occurred and if a cardiac arrest occurs, then the best way to improve that person's survival is defibrillation. That's to give them a shock as early as possible to get their heart back to normal again. The way that needs to be done is with a defibrillator. So you probably have seen around in shopping centres and in airports and in public places, there's a lot of AEDs, so that's automatic external defibrillators that are available specifically to try and to cover this possibility. If somebody has a heart attack, becomes unconscious, they go into a cardiac arrest, then the defibrillator is designed to be able to give them a shock as fast as possible to try to restore normal rhythm. The danger here is that first of all, not the defibrillator may not be where the person is, but that has the cardiac arrest, and then sometimes trying to find that defibrillator or to get access to it in a timely fashion is a problem. So really, the holy grail would be to some way find a method of defibrillating people where the defibrillator was available, where the person is, and that's obviously a logistic challenge, but that would be the ideal, and to cover all of the eventualities so that really nobody is missed. 50% of all first heart attacks are fatal. It's a very sobering statistic, but it's important because before a heart attack occurs, the individual doesn't know they've got a problem. They may be totally unaware of it. And if the individual hasn't really been able to anticipate that a problem is going to happen, they haven't been able to take evasive action to prevent it from happening. The real issue here is that coronary artery disease can be a silent killer in the sense that the individual who has the problem doesn't know that they've got something brewing under the surface until something happens. There are ways that we can try to detect this to predict risk. We have various tools available, such as CAT scanning and risk assessments, etc., that are really very good at being able to identify risk, but we can't pick everyone. And we want to be able to prevent premature death. And the way that we try to do this is, apart from trying to control risk factors and decrease the overall likelihood of a cardiovascular event, because we can't prevent all cardiovascular events, we're trying to get people more prepared. And the way to be more prepared is to have access to emergency facilities. Everybody knows about ringing 000 if somebody collapses. But it takes time for the ambulance to arrive. And in those critical minutes, those first 3 minutes, somebody can die before the ambulance actually arrives. And so having emergency defibrillation available on site at the point where the event occurs, it can be absolutely life-saving. The capacity to defibrillate somebody, to get them out of their cardiac arrest and save their life, could make a massive difference to the overall survival of people who have out-of-hospital cardiac arrests.